Good afternoon, everyone. Welcome and thank you for joining our live lunch chat exclusively for Maybank. My name is Vivian, and today we have Dr. Ahmad Ashraf, our resident interventional cardiologist and physician, to give sharing on recognizing and treating coronary disease. Dr. Ashraf has a lot of experiences in dealing with cardiovascular disease. But before we start, allow me to brief you a little of Dr. Ashraf's background. Dr. Ashraf completed his undergraduate medical training at the Royal College of Surgeons, Ireland in 2000. After 5 years of internal medicine training, he began his specialist training in clinical cardiology in 2005. Hi, Dr. Ashraf. I shall pass this session to you now.
Thank you, Vivian. Hello, everybody in Maybank. Welcome to this live lunch chat. So today I'm talking about how to recognize and how to treat coronary artery disease. Now, I swear that somebody said this to me once, and I think it's a quote, but I can't really find it. So for now, let's just say I said it. To recognize what is abnormal, you need to know what is normal. So first we'll start with the normal coronary arteries of the heart. So this is a picture showing the normal arteries of the heart. There are 3 big arteries. There's 2 on the left, one that runs on the 2 on the left, one of them runs along the front of the heart, and we call this the left anterior descending artery. Then there is one on the left that goes behind the heart. We call this the left circumflex artery. And then there is one that runs on the right side of the heart. We call this the right coronary artery. Now the picture on the right hand side there, that's what it looks like on a CT scan of the arteries. And you see, you get a nice picture. The LAD is the left anterior descending, the LCX is the left circumflex, and the RCA is the right coronary artery. So this is what the artery should look like normally, nice and big without any blockages. This is what it looks like when I do an angiogram. This is where I put the tube up through the body into the heart, and I put dye inside. So you can see the dye shows up as black, and it goes down the arteries, and you can see that the arteries are open. Okay, this is not completely normal. It's very hard to actually find a normal angiogram when all you do is angiogram on sick people. But this is as close to normal as I can show. So that's the left circumflex artery here. This is the left anterior descending here. You can see it in this view. So you can see the left anterior descending is actually a very big artery. It runs down the front of the heart. This is a very important artery. It supplies the most important chamber of the heart. And when this one is blocked, you get a really big heart attack. This is the left circumflex that runs behind the heart. And then this is the right coronary artery. For about 70% of people, the right coronary artery is the bigger artery, and it supplies most of the right side of the heart and also part of the main chamber of the heart as well. So just take your time to appreciate what the artery looks like when it's nice and big and normal. So there's flow, the entire blood vessel has normal flow. Now this is an ECG. This is an electric reading of the heart, and it's useful because a normal ECG usually means that there isn't any problems in the heart. Okay. Now you can see that I drew black lines here. That's to show that in a normal ECG, this line should be straight. There should not be any changes from the baseline in a normal ECG. So I'll give you a case, and some people maybe in Maybank who've had heart problems, some of this might sound familiar to what you went through. So this is a 58-year-old man. This only happened this week. He has never really been to a doctor. He doesn't have any medical history that he knows about. He's not a smoker. And he came in on Monday. He'd been having chest pain from about 5 in the morning. It became very severe at around 8:30 in the morning. He decided to come to our hospital. He arrived around 9 in the morning. When he came to us, we quickly checked him out, and his blood pressure is super high. It's 199 over 150. So that's a very high blood pressure. The heart rate is normal. And we do this. This is his ECG. So I'll put the lines down again. So those are the lines. So remember, the line should be completely flat. But if you look here, you see this? The line is no longer flat. That is a raised part of the line. So we call that ST elevation. Okay, ST elevation on an ECG means it's a heart attack. Okay, it's the commonest cause for a heart attack. And because I know that these leads 2, 3, and AVF cover the bottom part of the heart, I know this is a heart attack affecting the bottom part of the heart, an acute inferior ST elevation myocardial infarction. Okay, so this usually means that the right coronary artery, the one on the right, is blocked. So what do? Well, we give him medicines, we give him blood thinners. Okay, in this case, we give him something called aspirin and something called Brilinta. These are 2 blood thinners. We also give him a cholesterol medicine because it does help. And then we do the primary angioplasty. This is to open up the blockage straight away. So on the right-hand side, there you can see the normal artery, what it looks like normally, the right coronary artery. On the left-hand side, you can see this person's blocked right coronary artery. You can see the blood flow stops right there in the middle. See, on this side, it's just normal flow. Here, it's blocked. So this blood vessel has been blocked from 5 in the morning. It's now 9:30 in the morning. So it's been blocked for 4.5 hours. So during that 4.5 hours, the right side of his heart is suffering a heart attack. So what do we do? Well, I try and put a wire down, and I was able to get the wire through the blocked part. So you can see the wire there. And now that the wire is through, there's some blood that can get through across with the wire. There's still a big clot of blood. So that's what happened, is a piece of blood clotted and blocked off the artery there. So once the wire is down, over this wire, I can put like a straw to suck out the clot. So that's what we did next. We put like a long straw to suck up this clot here. And this is what it looks like after we sucked up the clot. So now the blood flow is a lot better. You can now see that there's some blood getting towards the end here, but there's still a very bad narrowing where the blockage was. So this is the part where we put a balloon and then we put a stent inside. And this is the final result after we put the stent inside. So you can see the stent. This looks like a wire, looks like a fence from about there to about there. And now you can see that there's blood flow filling the whole thing. So this overall took about 35 minutes. And it restored the normal flow. His chest pain disappeared. So the first day after his heart attack, with medicines, his blood pressure has gone to normal. He doesn't have any more chest pain. He doesn't have any difficulty breathing. You can see that we did a scan of the heart here. So this is his heart here, and you can see that the squeezing of the heart is actually quite normal. All the segments of the heart are squeezing normally, so there's no major damage that's been done because he came early and we were able to open up the blocked artery. So this is a good ending for an acute heart attack. But Dr. Ashraf, why are we talking about heart attacks? Okay, this is the year of COVID-19, right? Wear your mask, lockdown. The graph might be difficult to see if you're looking on your phone, but that is a breakdown of all deaths in the whole world recorded since the beginning of the year up until the 2nd of July 2020. And you can see that the leading cause of death worldwide is heart disease. That's the top one. This is heart disease here. Okay, and as we talk, you can see the numbers continue to pile up. We're up to about 5 million deaths. This is in April. Now we're up to May and up to 6 million deaths worldwide from heart disease. You might say, where's COVID? COVID is actually here in the middle. And it's slowly rising up. But by far the leading cause of death worldwide, even with all the focus on COVID right now remains heart disease. Okay, you are far more likely to die from heart disease than you are from COVID. And the final result there at the beginning of July 2020, at this point, 9,600,000 people have died worldwide from heart disease. 5 million people have died from cancer. 500,000 people have died from COVID. Okay. And this is a very old slide. I did this slide about 4 years ago. It's still relevant today. You can see that heart disease affects everybody. It affects famous people. For example, Michael Clark Duncan, the actor from Green Mile, very big, healthy, big, strong-looking guy. He suffered a heart attack, and he died 2 months after his heart attack. The Sopranos actor, James Gandolfini, he died from a heart attack. They were unable to bring him back to life. His heart stopped during his heart attack. And then, of course, we have Tun M, who's still going strong, even though he's had multiple heart attacks in the past. And then if you look at the statistics in Malaysia, this is the number of deaths due to coronary artery disease from 2010 to 2018. And you can see that over that period, the number of deaths due to heart attack continues to climb up and up and up. And in 2018, heart disease accounted for 15.6% of all the recorded deaths in Malaysia, which is 18,267 people. And these are the 5 main causes of death in Malaysia in 2018, and number 1 is heart disease. And if you break that down, you can see that the majority of them are men. 12,510 are men, 5,757 are women. The majority are Malays, but there's a large number of Chinese and Indians as well. And the average is 50 people per day die from coronary heart disease. 50 people per day in Malaysia, okay? 5 people die from COVID makes the news. 50 people per day die from coronary heart disease is not interesting, right? But that's the facts. So now you know how common heart disease is and how likely you are to die from it. You need to know what causes coronary artery disease. So these are the big risk factors for coronary artery disease: high blood pressure, high cholesterol, diabetes, and smoking. If you look at the people who suffered heart attacks in Malaysia, 94% are older than 40, so age is a risk factor. 83% are men, so being a man is a risk factor. But these are what we call unmodifiable. You cannot get younger, and you cannot change your gender. I mean, technically you could, but you can't really. And then the 4 are the modifiable risk factors. These are things that you can do something about. So high blood pressure, 68% have high blood pressure. High cholesterol, 55% have high cholesterol. Diabetes, 45% have diabetes. And smoking, or 50% of people who have heart attacks smoke or used to smoke, okay? So when you have those risk factors, and as you get older, and if you're a man, what happens is, in the beginning, you have this normal blood vessel, nice and big, thin wall, and the blood is flowing through. But those things, high blood pressure, high cholesterol, diabetes, smoking, they cause damage to the inside of the blood vessel. And the response of your body to that damage is to try and fix it by putting cholesterol there. So the higher your cholesterol, the more cholesterol gets put at the areas of the damage. And this happens again and again, and eventually the cholesterol builds up until the passage becomes very small and narrow. So instead of a lot of blood being able to travel through, only a small amount of blood is able to get through. Additionally, that cholesterol that builds up is not solid, okay? Only the surface is solid. The inside is soft, fat, liquid. And when this cholesterol breaks open, because the surface is not very strong, the inside cholesterol comes out, the liquid stuff comes out, and when it meets with the blood, it will cause the blood to clot. That's the normal reaction, okay? And when it clots, it will block off completely the blood vessel, and the blood can no longer get through. And that causes death of the muscle because it's not getting blood, it's not getting oxygen. So this is what a heart attack is, okay? And you can see that the part of the heart that's been damaged becomes dark compared to the healthy pink tissue of the normal heart, okay? And this actually, you can see it on the postmortems. This is a person who suffered heart attacks, and then eventually he died from a fresh heart attack, and they did an autopsy and look at his heart. And this is the normal pink tissue. There isn't a lot of normal pink tissue in this person. Here is still some normal pink tissue. The white stuff is old heart attack. So that part of the heart has become damaged and now has turned into scar. So scar looks like white. And the black area, you can see there's a lot of black area. This is the fresh heart attack. And you can see how this person suffered such a big heart attack that almost the whole front of his heart was badly damaged. And that's why he died. So, for everybody watching, now it's time to see how many risk factors do you have. I'll take me, okay, I'm a guy, so that's one risk factor, okay. I didn't do anything, I'm just a guy, but that's one risk factor. I'm 44 this year, so I'm over 40, so that's two risk factors, okay. Thankfully, my blood pressure is fine, I check it regularly, so my blood pressure is 120/70. My cholesterol, the last time I checked it was borderline, it was around 3, which is a bit above the normal. So I could say I have mild high cholesterol, okay? So that's a risk factor. I don't have diabetes and I don't smoke, okay? So that gives me, what, 3 risk factors, okay? That already puts me at a moderate risk for having coronary artery disease, okay? So you can do this yourself, you can see how many risk factors you have. The more risk factors you have, the more likely it is that you have coronary artery disease. Okay. So I have risk factors. How do I know if I have coronary disease? The next step is, do you have any signs, any symptoms of heart disease? So if you have a blockage or narrowing of the blood supply to your heart, what happens is when your heart is working harder than normal, it will become stressed. Okay, it doesn't get enough oxygen, doesn't get enough blood, it will hurt. So you can have chest pain. The chest pain can be anywhere from your neck, your jaw, to above your belly button. So any pain anywhere there could be from your heart. Okay? It doesn't have to be in the center of the chest, although it typically is, but it doesn't have to be. It can be in the back, it can be on the left-hand side. Sometimes it's not in the chest, sometimes you can get pain in your arm, usually your left arm, sometimes in the left shoulder. Some people get just bad pain around the jaw or the neck, okay? And then sometimes in women, for some reason, they get pain in the back. When you have a bad narrowing and your heart is stressed, your body responds to the stress, and sometimes people get sick. They feel like they want to throw up. When the heart can no longer work properly because it's not getting enough oxygen, it'll tire out. So people will report that they get tired easily. If they can normally walk up 3 or 4 flights of stairs, now walking up 2 flights of stairs, they get tired. So reduced energy. When they try to push harder, they become out of breath. So shortness of breath, okay? And then some people, they get this unnatural sweating. Even when they're not doing anything too heavy, they break out in cold sweat. Sometimes they get dizzy. So the symptoms, the commonest one is chest discomfort, chest pain, and then it's shortness of breath, then it's reduced effort tolerance, you get tired easier than you should, and then the other symptoms, fatigue, sweating, nausea, dizziness, okay? When it's in the early stages, when the blood supply is narrowed but not completely blocked, these symptoms tend to happen when you're doing extra physical activity, more than you normally do, okay? As the narrowing gets worse, then it will become more frequent, and eventually it will happen even if you're doing very minor things. Okay, so when you get to that stage, that's already quite advanced. All right. So you've checked yourself, you have some risk factors, and now you've gone through the symptoms and you're thinking, oh, okay, maybe I have some symptoms. I've noticed recently when I walk, I get a little bit out of breath. When I walk up the stairs, I have to rest. What should I do next? Find a doctor. Okay, it doesn't have to be us. You can go see a GP, but you need to see a doctor so that they can assess things, all right? Okay. What if I have risk factors? I'm on treatment for high blood pressure and I smoke, but I don't feel any symptoms. I feel completely fine. What should I do? Find a doctor. Okay, you have risk factors. You need to assess it further, see if you actually have underlying any coronary disease. Well, I don't know if I have any risk factors. Okay, I never really checked my blood pressure. Like our patient in the beginning, he never really checked his blood pressure before, so he did not know that he had high blood pressure. And I don't smoke, and I feel fine, but I'm worried. What should I do? Find a doctor. Okay. If you're worried. If you're not worried, then that's fine. So what should the doctor do? Well, if you go see the doctor and you say that, listen, I have these risk factors and I'm worried that I might have a heart problem, then he or she will listen to your story, ask you some questions. Do you have chest pain when you walk? You get short of breath when you walk? Can you normally do the things that you normally do? Or now you have to stop and rest? Do you exercise? Do you play sports? Can you still play sports? Do you have to stop? Do you ever feel dizzy when you exercise? Do you ever faint when you exercise? Then the doctor will do an examination, listen to the heart, check the blood pressure, check the heart rate. After that, normally they'll decide what's the next appropriate test to do. So this is the first test that they could do. They could do an ECG, electrocardiogram. It's the simplest test to do. You attach the electrodes and it records the electrical activity of the heart. Okay, I'm quite fond of an ECG. Because a normal ECG is very useful. Normal ECG tells me that person has never had a heart attack before. Okay, an abnormal ECG is sometimes useful, especially if it tells me if an acute heart attack is happening, but usually that person is having severe chest pain. So ECG, very simple test to do and quite informative. The next test after that is a treadmill test. This is where a person runs on a treadmill and we still do the electrical reading. And what we want to see is when the heart is under stress, does the electrical reading change? Okay. Now, it's a very common test. It's relatively not expensive, relatively. There are some requirements. You need to have a normal ECG. So if your ECG is not normal, the stress test is not that helpful. You cannot interpret the reading, okay? The person must be able to walk, at least walk, okay? If a person is very overweight or has any leg problems and is unable to walk for at least 5 to 9 minutes, then it won't be helpful, okay? You have to get to at least 85% of the target heart rate. The target heart rate depends on your age. How accurate is it? It's about 60 to 80% accurate. Okay, it's not 100% accurate. That means even people who have a normal treadmill test can still have heart disease, but it's unlikely. Okay. So most people will have had experience doing a stress test because a lot of doctors will offer it, a lot of centers will offer it, and we offer it as well. This is an example of what happens with the treadmill test. So instead of the ST segment going up, it goes up during a heart attack. With a stress test, it goes down. Okay, a normal stress test, it won't change; it will just stay flat. Okay, so this person developed ECG changes after 4 minutes of running. So this is, we would say, a positive stress test and moderate effort. The next test that we could do is echocardiogram. So this is an ultrasound of the heart, very similar to pregnant women having the baby scan. So for pregnant women, it allows them to see what the baby looks like. Is the baby healthy looking, have all the normal arms and legs, etc. So similarly for the heart, we can see the shape of the heart, we can see the size of the heart. The dots there are centimeters, okay? So using that, we can judge the size of the heart here. We can look at the walls. This is the main chamber of the heart. We call this the left ventricle. This is the front wall of the left ventricle. This is the back wall. And it's important that we can see that all the segments are squeezing normally. Okay, so everything's squeezing nice and synchronous. Okay, this is the mitral valve here, opening and closing. This is the aortic valve, opening and closing. So this is all seems to be functioning normally. This is another view. This is the left ventricle. This is the right ventricle, the right side of the heart. But the left is actually does most of the work. And again, we can see that all the walls are squeezing normally. The valve is opening and closing normally. So this is what a normal echo looks like. This is an example of a damaged heart. Okay. So the heart, you can see that this is much bigger compared to the last scan. So if you measure this up, this is probably around 6 centimeters. 1, 2, 3, 4, 5, 6 centimeters. So that's bigger than normal. Okay, and the squeezing, you can see that only this bottom part of the heart is squeezing. This part here isn't squeezing at all, and neither is the front part of the heart here. So this is an enlarged, weakened heart. This is a person who suffered a heart attack some time ago and severely damaged the heart. Okay, and this is the same heart again. You can see that only the bottom part here is squeezing. The rest of the heart here is not really squeezing at all. Some part of the bottom here is squeezing. So this is heart failure. This is what we call jantung bengkak. Okay, and this is from a heart attack that wasn't treated in time. So when I spoke about the running test, some people cannot do the running test because the electrical reading is not normal, or because they cannot run. Okay. Elderly people, people with back problems, people with leg problems who cannot do run. We can still do a similar test. We call this a stress echocardiogram. So it's not as expensive as a CT scan. It's suitable for people who cannot exercise. We give a medicine called dobutamine. We give it through the vein into the blood, and it makes the heart squeeze harder. Okay, it's more accurate than the stress test because we can actually see changes in the muscle of the heart when there's not enough, when the heart is working harder and there's not enough blood supply. It is more expensive than the running test. And this is an example of what it looks like. So at the beginning here, this is before the medicine is given, and as the medicine is given, the heart squeezes harder and harder and harder. We've done quite a few of these dobutamine stress tests here. So far, I haven't had any positive ones yet, so I cannot show you what a positive one looks like. These are all normal. The next step after that is you can do a CT coronary angiogram. So in the CT coronary angiogram, one of the veins here is accessed, a needle is put inside. You lie inside the CT machine, then dye is given through the vein, and the dye will travel in the bloodstream, and then eventually the dye will reach the heart. The CT machine can detect when the dye reaches the heart, and then the CT machine will take a lot of slices of the heart. So you need at least a CT that can do 256 slices to get an adequate quality picture. You need the heart rate to be slow, below 60, around 60 is ideal. You can get pretty good pictures. It will show any areas of narrowing. So for example, here, where the arrow is pointing, that's a narrowing from cholesterol. It can show areas where the cholesterol has hardened and become calcium. And the advantages, it's not invasive, there's no tube going straight up into the heart. So the risk of causing a stroke or causing any injury, there is none of that risk. There is still dye going in, so there is a small risk that you can damage the kidneys from the dye, but that's the same risk as doing an angiogram. The accuracy is around 90%. Okay, centers that do a lot of the CTs, the accuracy will go up because they get more experience. Centers that do a certain amount, the accuracy is usually around 90%. Okay, but the picture you get is quite good. And again, just an example of the picture quality that you can get. So, for example, in the middle segment here, there looks like there's two narrow wings which look severe. The lower one actually looks more severe than the upper one on this CT scan. Now, the drawback is it's not as accurate as an angiogram. You can classify the narrowings into mild narrowings, moderate narrowings, or severe narrowings. It's very hard to give it a number more accurate than that. Okay. If there's a lot of calcium inside the arteries, so this is somebody who's had a lot of cholesterol inside the blood vessel, which have identical calcium. The more calcium there is inside the arteries, the less accurate the CT will be because it cannot adequately penetrate the calcium. Okay. You cannot fix anything from a CT. You can only diagnose. It's a diagnostic test only. So there's a narrowing that you still need to do an angiogram. So that means that if, for example, a person had a heart attack and came and saw me and I said you need to do an angiogram, but that person is worried about the angiogram and says he wants to do a CT, I say, okay, that's fine. You can do a CT first, but you probably still need an angiogram. Okay. So sometimes I've had some patients become upset because they did the CT first and then they still need an angiogram. They feel like we could have skipped when they originally asked to do the CT in the first place. Okay, that's just the way it is. And then this is the same person, CT first and then had an angiogram later on. And you can see that on the CT, both these narrowings look bad. But on the angiogram, the upper one actually was not bad, only the lower one was bad. Okay, and then on this one, the narrowing is captured correctly on the CT scan, confirms all this is bad narrowing here. But the angiogram, you can also see that the other blood vessel also had a bad narrowing. You can see both at the same time, whereas on the CT, you kind of have to focus one by one. And then one other machine that we can do is MRI, cardiac MRI, and sometimes we get requests from patients asking if we can do a cardiac MRI to see if they have a blockage or not. Now, cardiac MRI is very good for looking at the shape of the heart, for looking at the valves of the heart, and for looking at the overall function of the heart. It's not very good. You cannot see the arteries from an MRI. Okay. It's not possible. You can do like the stress echo, you can do a stress MRI where you give a dye and you get the patient to exercise and you see if the dye goes around, fills the entire heart or not. Okay, it is not more accurate than the stress echocardiogram and it's a lot more expensive. Additionally, the scan will take a long time. It can take anywhere from 40 minutes to an hour to do. It's very noisy, and you have to sit inside this corridor tunnel for a long period of time. So people who are claustrophobic, it wouldn't be good. Okay, so cardiac MRI, the use usually is if a person has many bad blockages, but we're not sure if fixing all the blockages would help. If the damage has been done already and the person already had a heart attack, sometimes fixing the narrowing will not improve anything. So MRI would actually let us see that part of the heart where the narrowing is it still healthy? If we fix it, will that part of the heart recover or not? Okay, so we use cardiac MRI for something we call viability. That's to see if the tissue still has a chance to be saved. This is an example of what the picture you get from MRI. So you get a beautiful picture of the tissue of the heart, the shape of the heart, and the valves. But you can see, like, there's no way you can see the coronaries from an MRI. They're too small. And then finally, you can do an angiogram. So the coronary angiogram is the gold standard. This is our lab at the very beginning before we filled it up. This is before we opened up. I should get a newer picture. Advantages, angiogram allows for repair. So if we did an angiogram and we confirm that there's a narrowing, usually we can fix it straight away. Okay, so we can go from the angiogram straight to angioplasty. Not all the time. If there's many narrowings, sometimes we have to stop and we have to make a plan of what to do. Drawbacks. It's invasive. You have to go in through the arm here, or you have to go in through the leg. We pass a tube up, has to travel through the arm or through the leg, and there's a risk that as the tube is traveling, it can cause a stroke. Stroke is where a clot or piece of cholesterol travels up into the brain and blocks a blood vessel there. Okay, so the risk of stroke is about 1 in 2,000, right? And then it's expensive. Okay, compared to the other ones, it's probably the most expensive test here. So I'll give you an example of a case. This is a 57-year-old Indian man. He has risk factors. So he's a man, he's over 40, he smokes, he has high blood pressure, he has high cholesterol. He's had the high blood pressure, high cholesterol for 5 years. He's smoking since he was 15. So he's been smoking a lot. He's been having chest pain when he walks for the last 3 weeks. So he has he has 5 risk factors, he has symptoms. Already, even without doing any tests, we are quite sure that he has a problem. He went to the government hospital where they did the running test, the treadmill test, and he ran for 4 minutes, he developed chest pain, and he developed ECG changes, so positive stress test. He was put on all the correct medicines, but because of the waiting list, he was given an appointment for the angiogram 2 months away, which is not that far actually, quite good. But unfortunately, his pain is getting worse, and therefore he came to see me. So because all the tests have been done, all the investigations have been done, I didn't have to do any investigations. Instead, we listed him for the angiogram. So this is his angiogram, okay? So actually, the big blood vessel along the front of the heart is completely blocked in this case, okay? Completely blocked. There is no flow down it anymore, okay? And then when you look in a different view, you can see that the circumflex, the artery that's running behind the heart, that also has a very bad narrowing. From here all the way down to here, there's at least a 90% narrowing there and a 90% narrowing there. This is the one on the front that's completely blocked, okay? So why did this person not have the full-blown heart attack like the other person? Because the one on the left that is completely blocked, that happens so slowly, his blood supply on the right actually managed to grow new branches and is actually sending blood to the one that's blocked. You can see it filling here. But the reason he's having trouble now is the one on the right has developed bad narrowing here as well. So this one on the right not only is sending blood to the right hand side, it's also sending blood to the front of the heart. And now that it has a bad narrowing here, he's getting worse chest pain. So we managed to fix everything, managed to open up the one that was blocked, fix the one behind that was severely narrowed. This is what the one on the front that was blocked looks like after we open it up. The big part is actually where the stent is, and then the rest of it, even though it's opened up, is still small. This is not unusual because it's been blocked for so long. It takes time for it to kind of grow bigger again. And then we also fixed the one on the right hand side, okay? So in conclusion, even though this is the year of COVID, coronary artery disease is still the leading cause of death worldwide. You're much more likely to die from heart disease than you are from COVID. The main risk factors are being a man, older than 40, high blood pressure, type 2 diabetes, high cholesterol, and smoking, okay? High blood pressure, type 2 diabetes, high cholesterol, and smoking, these are modifiable risk factors. You can treat them. The more you treat them, the lower your risk of having heart disease. Smoking, you can stop smoking. It's important that you find out whether or not you have these risk factors, and if you do, you need to treat them, because treating them will lower the risk of heart disease and prevent you from getting a heart attack. And then finally, if you are worried, you should go and do the test so that we can find out if you have any coronary disease and we can address it before you develop a heart attack. Thank you.
Thank you, Doctor. So we have received tremendous feedback and question. Thank you everyone for the overwhelming response. I believe some of the question has been answered during the talk. We have listed the few questions that were not addressed in the slide. So Doctor, the first question is,
Okay.
What is the suitable exercise for women at age 50 and above?
Okay, so the adequate exercise should be for anybody, including women 50 and above, would be cardiovascular exercise, which is walking, jogging, cycling, enough to make your heart go fast and make you sweat a bit harder, make you a little bit out of breath. Okay, and you should do between at least 40 minutes of that at least 3 times a week. Okay, so for example, what I would recommend is go for a walk, maybe in the morning, maybe lunchtime, walk for about 40 minutes at least, enough to make you sweat, enough to make you short of breath. Go to Bukit Padang, go to the park and do this, or you go anywhere that you like.
Okay, next question, Doctor. Causes of death happen during sleep?
Okay, so dying during the sleep, okay? So it's interesting. What's important here is the dying suddenly, okay? Dying suddenly can happen at any time. It can happen during sleep, it can happen when you're exercising, or it can happen when you're just resting, okay? So it's the dying suddenly that is the actual question. Whether or not it happened during sleep is not that relevant, okay? So dying suddenly or sudden death, you can divide by the age, okay? Under the age of 40, dying suddenly is usually due to either an electrical problem of the heart or a muscle problem of the heart. Okay? When you look at the football players, the professional athletes who died suddenly, they usually have a muscle problem of the heart. It wasn't picked up, and their muscle was too thick, and when they were exercising or even during sleep, the heart just stopped. Okay, that's called a cardiomyopathy. The commonest one is hypertrophic cardiomyopathy. So under the age of 40, that's one of the leading causes of death. The other one is an electrical problem of the heart. So there's a few conditions that we call long QT syndrome or Brugada syndrome. These are problems with electrical channels in the heart, and they cause people to die suddenly, and they're one of the leading causes of people dying suddenly under the age of 40. If you look at people over the age of 40, the commonest cause of dying suddenly is a blockage or severe narrowing in the blood vessel of the heart. Okay, so these people who die in their sleep or die playing badminton when they're over 40, what happened is the blood supply cut off, they had a heart attack, and in people who have heart attacks, 10% of people who have heart attacks, the heart will just stop. Okay, that's it. That's the first sign of the heart attack. So unfortunately, these people were part of that 10% who died suddenly during a heart attack.
Okay, next question. Heart patients must be on medication for the rest of their lives?
Oh, good question. Heart patients must be on medication for the rest of their lives. There are 2 different kind of medical conditions. One is an acute medical condition. For example, if you have a chest infection, so what happens is bacteria enter your chest, it causes an infection there. You need to take antibiotics, the antibiotics will kill the bacteria, then the bacteria is gone, and the infection is gone, and then you no longer need to take the antibiotics. Or for example, you have gout. So gout is when one of the joints becomes very painful. You need to take some medication to relieve the pain and to reduce the inflammation. You take that for 5 days, the gout is gone, the joint goes back to normal, you can stop taking the medication. Okay, those are conditions that can be cured, they're temporary. Heart conditions usually are not temporary. Most heart conditions are not temporary. They're due to either high blood pressure, high cholesterol, or diabetes. And once you have the condition, right now, there is no cure for it. There are medications that can manage the condition. When you take the medications, you lower the risk of having another heart attack, you lower the risk of having another stroke, okay? And it's not that you must take the medications for the rest of your life, it's that when you take the medications, you lower the risk. So let's say with all the risk factors and having heart problem, your risk of having heart attack is 60%. When you take the medications, your risk of heart attack goes to 20%. Okay, you stop taking the medications and you will feel fine, but your risk goes up to 60% again. If you take the medications, it goes down to 20% again. That's the nature of it. It's not that you have to take the medicine forever, but as long as you have the condition, the risk will always be there. As long as you take the medicine, it will lower the risk. When you stop taking the medicine, it'll go back up.
Okay, next question, doctor. What are the new approved medical treatment or medicines which are less harmful to our body?
Okay, so this is an interesting question because the way it's asked, it suggests that the current medicine is harmful to the body. So most treatments for the heart are treatments for high blood pressure, for high cholesterol, for diabetes. And most of these treatments have been studied extensively for the last 30 years. And most of the studies, or almost all of the studies, have this category where they look at the benefit. So that means when you take the medicine, does it make you live longer? Does it reduce your risk of heart attack or dying or having a stroke? That is the target part of the study. There is also another part of the study where it looks at the adverse side effects. So it looks at the effect of the medication on the kidneys, it looks at the effect of the medication on the liver, it looks at the effect of the medication on other things, like does it increase the risk of bleeding, does it increase the risk of dying. And all the medicines that we use routinely to treat heart disease, high blood pressure, diabetes, cholesterol, they will not make it to market if they had very bad side effects. Okay, so the medicines for high blood pressure, almost all of them actually protect your kidneys from damage. The medicines for diabetes, the majority, not all of them, the majority of them have beneficial effects, especially like, for example, the newer ones, SGLT1 inhibitors in particular. Example, Forxiga, Jardiance. These medicines actually, in addition to controlling diabetes, will lower your risk of heart attack, lower your risk of stroke, lower your risk of progressing to kidney disease. And then cholesterol medicines, also extensively studied, slightly increased incidence of diabetes with the cholesterol medicines. And then a very rare situation, less than 1 in 100,000, that cholesterol medicines can develop this condition where you get where it can damage your kidneys. But it's extremely rare. It's 1 in 100,000. Okay. By and large, medicines that we use to treat heart disease are already like safe and not harmful.
Okay, next question, doctor. I had a heart surgery in 2006. After 10 years, how long can I live? And usually, can a heart patient survive after 20 years of surgery?
All right. So to whoever asked that question, congratulations, it's 2020, so it's already 14 years. So the heart surgery, it depends on what kind of heart surgery you had. Heart surgery can either be, for example, you had a bypass, a coronary artery bypass for bad blockages. So in that surgery, you take veins from the legs and you attach them to bypass, make a shortcut over the blocked arteries. So a bypass normally will last between 8 to 15 years. Okay, the veins will last that long, between 8 to 15 years. 8 years is usually the earliest you would expect to run into trouble. And the longer it goes on from the time you have the bypass, the more likely it is that the veins will wear and tear and develop problems of their own. Okay, so for bypass, I would expect minimum 8 years before you run into trouble. If the heart surgery was for a valve replacement or valve repair, then that's different. So if you had a valve problem and it had to be repaired, if the repair is good, usually you won't run into problems again. If it needed to be replaced, then it depends on what type of replacement you have. The replacements can be metal replacements, or you can have tissue replacement. The tissue replacements are usually made from cow tissue, sometimes pig tissue. If it's a metal replacement, the metal ones usually last forever. You need to take blood thinners for the rest of your life because it's metal, but usually they will function well forever. So if you had one of those, it'll probably last forever. If you had a tissue valve, the advantage is you don't need to take the blood thinners after the operation. They don't last as long. So if it's a mitral valve that's replaced, it will last maybe 12 years. If it's an aortic valve that was replaced with a tissue valve, it will last maybe 10 years. And then you might run into problems.
Okay, next question. Is it safe to take statin in long run? Heard it can damage the kidney.
I think I covered that already. So statins is cholesterol medicine, okay? My opinion on this, on statins. Statins are very good for controlling your cholesterol. Do you absolutely have to be on a statin? No. Unless you've had a heart attack. If you've had a heart attack, you should probably almost definitely be on a statin. But if all you have is high cholesterol and you've never had a heart attack before, and you come to me and say, doctor, I want to try diet first, I think that's fine, okay? But you need to be very strict. You need to cut eggs completely out of your diet. You need to really reduce the amount of fatty foods that you take, and you need to maintain this for the rest of your life, okay? I've had patients who come to me with this, and I say, okay, fine, you can try it. And usually they can maintain the really strict diet for a while, but they can't maintain it forever. And then they relapse, and then the cholesterol will go back up. So if you don't want to change your lifestyle, but you are worried about your cholesterol, you can take a statin, okay? And statins, 99% of the time, they do not damage your kidneys, okay? That one time is the less than 1 in 100,000 cases, you can develop a condition called rhabdomyolysis. Rhabdomyolysis is where the muscles all become damaged and break down. The person who has rhabdomyolysis, everything will be very painful, and the person will be very, very weak, wouldn't really be able to stand up without help. If that happens, you stop. If those symptoms happen and you're on a cholesterol medicine, you stop the cholesterol medicine, you go see a doctor, okay? The few cases where people have died is they did not recognize the symptoms, they continue taking the statin, and the muscle breakdown clogs the kidneys, and then they develop kidney failure and they die, okay? But that is the exception.
Next question, doctor. Why I still need to continue taking Lipitor and Plavix, although the cholesterol level already down to normal level? What happens if I taking above pill in alternate day? And what side effect will I get if taking those medicine together with supplement tablets, for example, vitamin C, bilberry, or salmon omega?
All right, so can you say the first one?
Why I need
All right, why do I need to take medicine? So as I explained, heart disease is a lifelong condition. It's no cure. So the medicines lower your risk. Okay. So if you want to lower your risk, you want to reduce the risk of having a heart attack, another heart attack in the future, another stroke in the future, you take the medicines. So as I said, without the medicines, your risk may be 60%, maybe higher. With the medicines, it will drop down. Whether you want your risk to be low or high, that's your choice. Okay, but you have to stick with your choice. You cannot decide, I'm happy with a risk of 60% and stop your cholesterol medicine. Then you get another heart attack, and then you feel bad because you got another heart attack. You make that choice. You want to stop the medicine. Okay, so nobody will force you to take the medicine, but as long as you take the medicine, you lower your risk. Okay, with regard to supplements, most supplements are fine. You need to be careful with some herbal supplements because they do have effects that are similar to the medicine. Some herbal supplements can thin your blood, for instance. So if you're already on blood thinners, it may become too thin, and then you're at higher risk of bleeding.
Okay, next question. Is numbness and tingling pain on your leg is a symptom of weak concern on blood flows, which may cause from heart problem?
So if you have risk factors and you are at risk of developing heart problems, The commonest one is the narrowing of the blood vessel. So the narrowing of the blood vessel can happen in any part of your body. It doesn't have to be your heart. So you can develop narrowings in the blood supply to your legs. And if you have a problem with the blood supply to your legs, one of the things that happens is you will get pain and weakness when you walk, usually at the calves, the back of the legs. When you walk a certain distance, they become tight, and then you have to stop walking. So that if you experience that when you walk after a certain period, the calves of your legs becomes painful and tight, and you have to stop walking. That's a sign of narrowing of the blood supply to your legs, and it may be a sign that you have a narrowing in the heart as well. If the main problem is numbness of the legs, that could be due to other things. Sometimes diabetes can cause that. Sometimes a spine problem can cause that.
Last question, doctor. Can heart attack happen only with one symptom?
Actually, heart attacks can happen with no symptoms. I've had patients who we only found out they had a heart attack when they came in for screening, and we did some tests, and we found out that they actually had a heart attack some while ago. They never noticed it, but heart has already been damaged. So it's actually quite possible that you could have no symptoms. So it is very possible that you can have a heart attack with only one symptom.
Okay. That was the last question we have for today. So before we end, doctor, do you have any message for our viewers?
Again, I'd like to thank Maybank for taking the time to spend your lunch watching me talk. It's not the most interesting thing in the world, but I hope you learned something from it. And take-home message is, if you have risk factors and you haven't been checked out, please go checked out. Okay. If you're worried, just go see a doctor, have a check first. Okay. You don't necessarily have to get checked out. Thank you.
Thank you so much, Dr. Ashraf, for the updates. I believe our viewers out there receive a lot of useful information from you in this session. Thank you once again.
Thank you, Vivian.
We have come to the end of our live today. Thank you everyone for watching us. And please do check our Facebook, Gleneagles Kota Kinabalu, as we will keep on posting updates from time to time. If you're interested in any other topics, please let me know. My email is vivian.peter@parkwaypantai.com, or you can WhatsApp me at 016-78-8475. Thank you once again, and see you next time.